have about 49, 50 attendees, plus the 10 panelists. So whenever you're ready.
Great. Are we on? We're on, right? You can go. Hi, good morning and good afternoon or good evening to everybody. We are the viral load suppression and scale up session. I just want to thank you all for joining today. I am Lana Lee. I'm one of the medical officers in the adult clinical branch of the Prevention Care and Treatment Division here at USAID Washington. And then Latham, do you want to introduce yourself as well?
Sure. Good morning. Thank you all. And I'm a data analyst over at USAID Washington as well with OHA. I'm the coordinator for this session. Thank you.
Thanks. And I will be moderating, and we have three wonderful presenters who are representing Zambia, Tanzania, and Nigeria. And we'll be addressing some of the different ways that their programs are contributing to the third 95. You know, as a third and final 95, it's arguably the most critical to reaching epidemic control as it represents the clinical goals for PLHIV who are on antiretroviral treatment. And by reaching viral suppression, we all know that PLHIV will be able to achieve the ultimate goal of living long and healthy and productive lives. So that's our ultimate goal. But from a public health perspective, as you know, it's critical to reaching, viral load suppression is critical to reaching epidemic control. And the messages such as U equals U or undetectable equals untransmissible really highlight the importance of this third 95 for interrupting the HIV transmission cycle. So we're hoping in this session that the presentations will help to clarify some of the gaps or barriers to viral load coverage and suppression and how each of these programs have developed some solutions to address these issues. And importantly, we also hope to spend some time as well to discuss how partners are building relationships with each other and networking also between and with local partners and other partners and stakeholders. So with that, I'm gonna ask Mr. Mwanza Katunga from Development Aid from People to People in Zambia to open up with our first presentation. It'll be followed by Mr. Mukunda Kasungo to talk about effectiveness, sample and results tracking systems in Tanzania. And then finally, but not least, our Pro Health International represented by Mr. Akinwale Ogundipe from Nigeria to present on his session on using electronic and mobile platforms. We are going to spend, we're going to try to leave, like I said, about 20 minutes at the end to talk. So I'll be pretty strict about trying to keep time for everybody. And with that, let me officially turn it over, Mr. Katunga.
Good afternoon, good morning, good evening, everyone. I'm Frederick Katunga Mwansa, representing Development Aid from People to People, Zambia. And I'm going to present the USAID PEPFAR OVC-funded project, a Zambia Family Initiative called ZamFam South Central in short. You can see on our logos, DAPP is Development Aid from People to People works in collaboration with the government of Zambia and especially the Ministry of Health, the Ministry of Agriculture, Ministry of Community Development and Social Services, among others. You also collaborates with international and national local partners at all levels in the operation areas. Development Aid from People to People is affiliated to International Federation for Humana People to People. And let me also mention that the Development Aid from People to People Zambia is a locally registered organization that has just 30 years since its start of the program in contributing to the Zambia development and working with the people in Zambia. And it's working in different areas like agriculture, health, environment and community development, second-hand clothes, sale, just to mention a few. Next slide. In 2017, 72,000 children aged 0 to 14 years were living with HIV in Zambia. According to PEPFAR data presented in April 2019, 72% of the children had their viral load measured, and of those, 75% were viral load suppressed. DAPP is implementing a 5-year program that is a Zambia Family Initiative, which started in 2016 and is ending this November 2020 with funds from PEPFAR, USAID. And it's being implemented in 14 districts across the southern and central provinces of Zambia. The objectives of the project was to improve health, education, welfare, and protection for children affected by and infected with HIV, building resilience in their families. Between October 2019 and April 2020, the project saved 123,000 OVCs, of whom 11,190 were HIV positive. Next slide. Here we present the interventions. Interventions to support viral load suppression among children living with HIV. Provision of individualized case management to the children living with HIV and their families. And I must mention to this that we administered the case management process in all this, and also that the screening tool was used according to the guidelines. The monthly visits have been supported through the community health workers. Of each of them were assigned to each specific OVC, providing ART adherence counseling, including analysis on the viral load, social, and other support according to their case plan. Now, the whole project had 924 community health workers. And these community health workers, they do not just support the child by looking at adherence, but also the well-being of a child. You can see on the picture there is a community health worker conducting testing, and the child is seated and the mother is there, or the guardian is there. The project also organized children living with HIV/AIDS 12 to 18 years in 320 teen clubs for provision of peer support and targeted intervention from health facility staff. So working with the peers, we established these teen clubs within the local areas where the children of this age were able to meet and gather and have the activities within the health facility to encourage themselves, to get health education, to get some encouragements and support from the health staff. We formed formation of 11,190. Those were the children living with HIV/AIDS. We formed of each of these a trio. And the trio consists of the child and the two supporters who could be their choice, either a guardian or a neighbor or a peer. And the support for the trio is on adherence to make sure that the child is taking medication. It is also to make sure the child is living healthy, the child can improve nutrition-wise, and all the other aspects that are needed to make sure that during the time the child is on treatment, they will be well, and therefore leading to suppression of a viral load. Next slide. Interventions to support viral load suppression among children living with HIV/AIDS. These are others. Training of caregivers to improve care and support to their children, including organizing them in action groups for mutual support and community interventions. Engaging the children living with HIV/AIDS in actions to take care of their own health and to be agents of change in their communities. There is a picture on the far right where you see women there, and also a few men. This is the organization of an action group. And the action group are formed within the village setup or the community where the children are living. And it's a mixed group. Of course, most of them are women, and always there are few men. Down on the left, you see there's a gentleman there, a peer, who is conducting the session for peer education to the youth. And then below in the middle, you also see the youth being trained in gardening. And then on the other side, you see a group of the youth discussing. And this is how the project has been working with the peer in teen clubs. Next slide. The results, 100% of the 123,000 OVCs served know their HIV status. And all of them were screened using the screening tool, and only those that were eligible were tested with their guardians. 100% of 11,190 children living with HIV/AIDS saved are on ARV and know their viral load. The suppression rates are currently reported at 90.8% on average, with a district rating between 72.2 and 94.8%, which is above the current average percent of 75. Activities were started in 4 new districts in September 2019, while the other 10 districts started in 2006 to 2017. Now I'll take you to the graph where you see the viral suppression in percentage. You see the first, it is the coverage, country average, which is 75. And in the district where the project was implemented for 1 year, you'll see that it went up to 82.20%. And in the other districts, that the 10 districts where the project was implemented for 3 years, it went up to 92.70%. And we think this achievement is good. The interventions applied in the Zamfam South Central project has proven effective in achieving viral load suppression for children living with HIV and is recommended for scaling up. And thank you. This has been our slide.
Thank you, Frederick. That was wonderful. We're going to hold questions because I'm sure there are a lot. And if people can, if you do have questions and you're worried that you might forget, please feel free to put them in the chat box, and we will get to them at the end. I just want to make sure that we have time for everybody to be able to present first. Wanda, maybe what we can do is we'll move to our next presenter. Mr. From Tanzania, Aisha Boresha Consortium. Do we have those slides? This is Ms. Mukunda Kasongo. And again, if you have additional questions for Mwanda, please put them into the chat box. Great, Mr. Kasongo, it's all yours.
Thank you. Good morning, good afternoon, and good evening. This is Mukunda Kasongo, representing Deloitte, Tanzania. I'm going to discuss with you our abstract with the title, The Effectiveness of Sample and Result Tracking System in Reducing the HIV Viral Load and DBS Sample Turnaround Time in HIV care and treatment services, focusing the case study of Southern Tanzania. On my presentation today, we're going to discuss in detail how the project have been supporting the government of Tanzania to use the electronic system on ordering of the HIV viral load and DBS sample at facility level. But again, how the system has helped the project in the country to reduce and monitor turnaround times for both samples and results from the testing lab. But again, how the system has been effectively used to send back the electronic results back to the facility where the sample was drawn. Additionally, how the system is used to electronically send alerts to unsuppressed results and rejection on time. So next slide, please. Before I go ahead, I would like to quickly give you an introduction. So this is USAID Boreshafia project. It's a 5 years program from December 2016 to December 2021. With regard to funding, we have PEFRA, MCH, Family Planning, RH, TB, and PMY initiatives, all through USAID. These big projects is implemented by a number of consortium members. The prime is Deloitte Consulting Limited, where other consortium members is Family Health International, IntraHealth, and Management and Development for Health. We have some goals where we wanted to improve lives of all Tanzanians. Next slide, please. Yeah, with regard to vision, we wanted to create, or have been creating, a dynamic, integrated platform for delivery of health services to all Tanzanians, which emphasizes strong collaboration between various stakeholders, including the government, facility that will support the number of community in all the region that the project is working. Next slide, please. I mentioned about the 4 consortium partners that are working on the project. Here are some of the roles and core function for each and every partner that are working together on this project. The prime, as I said, is Deloitte, where they provide strategic direction, but additionally they do provide and lead us on project and grants management, monitoring and evaluation. But again, they also working on organizational level, mentorship and training to all local partners to implement national guidelines and also harmonize the number of systems at national, regional, and district levels. And the 3 consortium members under Deloitte, we have the IntraHealth, who are taking lead on family planning, HIV, maternal child health integration, where they provide strengthening and integration of family planning and RH with HIV and other services within the project. But also they provide a technical assistance focused on FP, gender-based violence, youth, and key populations related services. We also have Family Health International, where the lead on HIV, TB, malaria technical approaches. So they provide the lead direction in HIV, TB, malaria, digital health initiatives to track delivery of care at all levels at the community facility, but again, building the capacity of local partners whom work together for continuous improvement, but again, inform program planning, data quality, and program service delivery. And the last one, but not the least, the MDH, they're also working with the project to implement comprehensive facility-based testing, care and treatment, national guidelines. But again, they're working on to implement laboratory quality management system, community testing, among many services they provide on the projects and the people they serve, both at the community and facility. Next slide, please. I would like to share with you the coverage. The project actually works on the 6 regions, as I had mentioned earlier. We're on the southern highlands of Tanzania. And there are 3 major result areas that the projects have been implementing for the past 4 years. Where number 1 result area is to improve enabling environment for health service provision. Result 2, improve the availability of quality integrated health service at facility level. And this abstract today, it will be focusing more on the result number 2. And result number 3, increase access to health services at the community level. The box on the right corner, it is the number of thematic areas on 6 regions that the project is working on, which cut across HIV, TB, family planning, and maternal and child health in Iringa, and other thematic areas, as you can see on the table. Next slide, please. So after that brief introduction of the regions, consortium members, areas, and the result area that will work as a project, please allow me now to take you through the development of sample and result tracking system. This digital health innovation helps to increase the access to care while making sure we enhance the efficiency of service delivery. As a project, as I said, working side by side with the government, we wanted to make sure we improve the HIV viral load patient outcome through increased visibility of the whole value chain from sample collection to results, but again, address some bottlenecks and also to be able to provide quick resolution for a number of challenges within the entire value chain. And as a project, we wanted to make sure that we have a complete value chain monitoring, at the same time providing the QI implementation. Due to the importance of the viral processes, we want to have a system that will give us, as a project in the ministry, an audit trail mechanism. At the same time, because we're working with the provider at the facility, we're able to provide real-time troubleshooting on the systems so that we can improve the program performance. But again, we know that we need a very quick and very short turnaround time. So this system actually address and reduce TAT so that we can increase the results action. And I must say that this technology is fully powered by the barcode technology. So the sample result tracking system, the way how it has been structured, it connects the hubs. So these are mainly the health center. And the facilities, the low-level facilities, this dispensary that are located around those health centers, connect those hubs with the regional and referral DNA PCR laboratories over the internet protocol, which I'll discuss here on the later slides. So far, this project has been implemented in 6 regions, and we started it back in October 2017. So we've been doing it incrementally from one region to another, and now we have covered the entire 6 regions that the project is supporting. The picture below summarizes how the sample is collected at the lower level facility or the hub itself. We have Korea, which for now we're working with Tanzania Post Corporation to transport the samples from the hubs all the way to the testing laboratory, the DNA PCR, and then the normal processes are the way on the laboratory, and then the sample, once they're processed, their results are available, they are uploaded back on the system and taken back to where the sample were collected. So if it was collected at the hub, the sample go back at the hub, they do printouts and send back to the lower level facility where the sample originated. Next slide, please. Now, please allow me to discuss with you methods. The program installed this system in 7 laboratories. These are DNA PCR laboratory, and we are supporting about 74 hubs. where samples are collected and processed. And the number of information that we are capturing during the course of the entire processes. We capture the time spent before sample have been registered, time spent in the hub after registration, but before sent out by the courier to the testing lab. But we are also capturing the time taken to deliver the sample from the hub to the testing lab. And as I said, it's powered by barcode technology. So we have the barcode form, which facilitates tracking of each sample in the entire batch of the sample that have been processed in that particular day or particular weeks. And when we are doing it, we've been working together with the government and the CDC and the USAID so that we do the entire process holistically. So as a project, we have been providing training to the technician of the lab, training to the district and regional management health council so that they can monitor the dashboard and reports at any point of time. For this abstract, we have extracted the data from the national repository. The system also implemented with other implementing partner. So we have extracted the sample and the data from the national repository. The trend in turnaround time for this abstract has been the past 4 quarters from April, June 2019 to January, March 2020. And you see on your right of the screen, so like the dashboard from the system itself, which gives you real time of what is happening from the hub to the lab, the Q results, the result from the testing lab today, or result from the lab in a given time, Q samples and all that. So that's the power of the system, which actually give us a lot of information of the sample and the status from the hub to the testing lab. Next slide, please. So the results. As I said, this was for the 4th quarter, April, June last year, July, September, October, December, and January, March. Over that period, we are able to process about 127,000 samples from 618 health facilities that the project is currently supporting. And in terms of results, about 84% of those sample went back to the facility and were disseminated to the client. And about 20,336, which is 16%, were still on the lab for various reasons, including machine breakout, availability of reagents, and the other reasons. The sample turnaround time for those 5 DNA PCR, as you see on the table right, we have the Ligura RRH. This is one of the testing lab that the project supporting. It was reduced by 22 days from 42 to 20 days. Iringa by 6 days, Njombe by 7 days, Morogoro 10 days, and St. Francis by 3 days over the past 4 quarters. And the table below, sorry, the graph and the picture you see indicate the result analysis from the system over a given period of time. I wanted to share with you so that you see the total sample, the total results. Out of those results, how many results were above 1,000 copies? Of those, how many were pregnancy? Out of those, how many were breastfeeding and the like for various laboratory? So this actually you can go deeper and deep dive to particular facility, to particular individual who had contributed to that. And this is how the system using those and suppressive results to alert particular facility to quickly follow up to that individual for additional interventions. Next slide, please. And the conclusion, we have seen from the project perspective that this digital health initiative has really contributed in reducing the turnaround time, but also track the time against various action from the hub to the PCR lab. But again, it has significantly reduced the workload that was originally being done within the lab. But we also believe it has seriously addressed the issue of accountability, because everything that is happening at different levels is able to be viewed by various stakeholders within the whole chain. As a project, we are looking forward to increase and to expand to more additional 15 hubs in those 6 regions that we work. And we're working with the team, making sure that we more customize the mobile version of the system so that the registration could start at dispensary level. And one but not the least, we want to make sure that we're able to integrate with care and treatment databases, because as we speak, it has not been yet integrated. So we're working on that area by following the same approach of stakeholder engagement, environmental scoping, making sure that we have proper device, as we currently support the devices, the internet bundle, time-to-time trainings and others, and also the change management and training. Next slide, please. So that takes me to the end of my presentation. Thank you.
Thank you, Mr. Kazunga. That was great. We are doing well on time. I just wanted to make a note that it looks like the chat box was having some issues with getting all panelists and attendees. So if you are having that issue, please go ahead and still send in your questions if it's only coming up as all panelists, and we'll copy your question back into group chat. It does look like some people are able to get to all panelists and attendees, so maybe just double check and see if that's possible. But we do have quite a vibrant discussion, which is great, going on right now within the group chat. So with that, please, again, just encourage you to enter your questions into the chat. And if it's coming out as panelists, we'll copy it in so that everybody can get it. And then I will, in the meantime, hand it over to, if we can put up our final presentation, which is in a poster format, but if I could just have that get pulled up while our speaker gets ready. This presentation will be led by Mr. Akinwale Ogundipe from ProHealth International. And so I will hand it over to you, Akinwale.
Okay, thank you very much. While I wait for the poster. Okay, good. Can you do some enlargement? Okay, great. All right, good morning and good afternoon, everyone. My name is Akinwale Ogundipe. I worked in Nigeria on the ICSA project. I work with ProHealth International. Basically, during my presentation, I will talk more about the ICSA project. So if I can go straight into my presentation. Sorry for my slide. Good. I was basically doing a poster presentation. So the idea of my work is a poster presentation on enhancing viral loads tracking among children living with HIV/AIDS using electronic mobile data collection. Okay, it's a pilot project. We had to quickly do this so that we can have an idea of the viral load suppression among our children. So a bit of background. Nigeria has the second largest HIV pandemic in the world. Although HIV prevalence among adults is much less, about 4.3% than others in sub-Saharan Africa. But then in 2017, 220,000 children 0 to 14 years in Nigeria were living with HIV. However, only 26% of this number were on antiretroviral treatment. The national survey that was done, the Nigerian HIV and AIDS Indicator and Impact Survey conducted in 2018, shows among children 15 to 19 years, 36.5% viral load coverage. You agree with me that this is far less than the 95% benchmark target by the UNAIDS target. Talking about the organization, okay, USAID in 2019 award 4 Integrated Child Health and Social Service Award, okay, to 4 local partners. ProHealth was one of the partners, and our award is to cover for Adamawa and Bauchi states. This is the Northeast region in Nigeria. The goal of that project is to reach 75,000 vulnerable children and their household. I would like to state that this project is a community-based orphans and vulnerable children project. But the work we do is to provide services for these children in their household. Our goal is to keep children safe, healthy, schooled, and stable, while supporting their household through economic strengthening, parenting skills, and what have you. So like I said, for us to be able to know how best to walk along the cascade, we conducted this pilot to be able to examine social factors, all those cultural factors, and any other factors contributing to viral load suppression among children. So my first figure down there is the Nigerian map showing Adamawa and Bauchi. Then the other map is showing the LGAs in Adamawa and the LGAs in Bauchi where this intervention was done. Let me go to the methodology. Okay, so what we did was to basically pick the National Care and Support Checklist. It's a tool that is being used by OVC program in Nigeria. So we picked the tool and designed it on a platform called Kobo Collect. Okay, Kobo Toolbox. It's open source software for humanitarian activities with good security features. So what we did was to design this form on that platform. Then we were able to push the forms to electronic mobile phones, Android mobile phones. From the Android mobile phones, we then engage case managers working in these LGAs on our program. We train them on how to use these mobile phones, do some text run with them before deploying them to the field to collect the data. So as you can see in my figure 2, that's the process we followed in my figure 2. Then after the collection, because it's an electronic means, they were able to do real-time data syncing, which was very good. So we could easily call and correct some errors where there is before the final download. So basically, in all, we're able to do 103 children living with HIV/AIDS. 75 of them were coming from the 4 LGAs in Adamawa, and 28 of them were coming from the 2 LGAs in Bauchi. So once they were finished this process, the form were synced to the web server. Then from the web server, my team were able to download these forms to conduct our analysis. As you can see, we're able to download in Excel. Again, that is in my figure 3. We're able to download this into Excel. Now the result. Okay, this is where for me that is very, very interesting and promising, because this is an electronic data collection. We're able to collect the geo-coordinates of the household of these children. That is very encouraging for me, because it's going to help in our contact tracing. Part of what we are doing with the treatment partner on the co-creation platform is to be able to have this geo-coordinate for all these children, so that during our co-creation platform meetings, we can also, share with them in such a way that if their case managers need to go to community, they can easily go straight to those households. So that was very handy for us. Then looking at the output of the exercise, we discovered that some children were on the borderline between Adamawa and Borno State, as you can see in figure 5. And looking at these children also on figure 6, where we live for attributes around viral suppression, those who are virally suppressed and those who are not virally suppressed. You can also see that looking at those children on the borderline, some were virally suppressed and some were not virally suppressed. Also, that is helping us to probing further, because these are children who are likely being served by the same community volunteers. So it's an avenue for us to ask the why question of how some of them are doing well with their viral suppression and some are not doing well. An interesting thing again that came up is to see that within the same state, Adamawa, for instance, we're seeing children in an LGA taking their treatment in another local government, okay? An example I gave in figure 7 was a child in Mayobewa LGA receiving treatment in a facility that is in another LGA. So this calls for concern for us to say that just like what we expressed during the COVID lockdown, the big question will be, how are these children able to have access to their medication? So knowing this set of children will help us to plan for them, to be able to ensure that whenever we have a similar thing in the future, they are able to access their medication. Because at the point in Adamawa, there was restriction on movement. So it's, like I said, it's a big concern, because for over like 2 months, people could not go outside their LGAs. So children in this category may not have done well. So that is an eye-opener for us to see that we can probe into that. The other one in figure 8 also, when we lay this children geo-coordinate against the coordinate of the facilities, we discovered that there is a child who is also taking his medication outside the state, in Taraba, in an hospital in Taraba. So again, that also goes to help us to think outside the box in case we have more of these children. Remember, this is a pilot, so we just did about only 100 something children compared to, we just did 103 children compared to the 2,000 plus children we have on the project. So this is also helping us to see that we may need to take that seriously, to ask ourselves, how well can we engage the household, through counseling to help these students to come back taking their medication within the state. Where that is not possible, how then do we still make their medication available to them? Okay, another thing that comes out of this as a result also for the caregivers that have mobile phone, we are able to track their next clinic appointment, okay? So for those set of caregivers, we're able to send them an SMS prior to that time just to remind them of their clinic appointments and to also check, on them to see how they are doing with the children medication as well. Okay, so in conclusion for us, it is very clear that this mobile app is not just only going to help us achieve real-time results, it is also going to be very useful for tracking the second and the third 95. Yes, this presentation is on the third 95, but the care and support checklist tracks information on this both second and the third 95. So for us, we felt that if we fully roll this out for all our beneficiaries, we will not only be tracking their viral suppression, for those who are not suppressed, we also have information around their drug regimens. Are they taking their drugs? If they mix their drugs, how many of them have missed their drugs? What are the reasons why they're missing their medications like that? So going forward for us is to first to say that we want to scale this up to all our CLHIV in both states. Another thing we want to do also is what I call the distance analysis based on where the students are staying to their facility, because again, that is another thing that we felt will help us to be able to do well with their viral load tracking. For those students who might be staying in hard to reach region, like I said, this project is in the Northeast. If you look at the map, somewhere up there is close to Brunei. Those regions are high risk region, and we have children in there. So doing our distance analysis, we could be able to tell if there are points where we could do a mobile pickup for these children so that they will be able to come pick up their medication with ease and be able to achieve viral load suppression. So basically that is the idea of our own presentation. I don't know if anyone will have a question, then I'll be able to provide more information. Thank you very much.
Thank you, Akinwale. That was great, and a really interesting example of using electronic mobile data within OVC programs. Just interesting on how you're getting different information out of there to help support CLHIV and ELHIV. So that's great. I think that maybe what I'll do, we have about 12 minutes left, I guess, to go through and maybe answer some, open it up to see if there are any questions that we can, that haven't been addressed in the chat box. Latham, are there any sort of priority questions? I also have a few questions, but I definitely want to get to make sure that the attendees' questions are addressed first.
Sure. Okay. Yeah, we have plenty of questions. First one is from Jacqueline Devine, and this was for Frederick Monza. And she was asking, what are the main drivers that motivate adherence based on the formative work that you've done? So Frederick, if you have any thoughts on that, you also might be on mute, so check that as well. And if you're having connection issues, we can also move forward.
Thank you. This is Masa. So the question about the main drivers that motivate adherence. So in this project, the main driver to adherence to treatment has been the TRIO system that has emphasized that a child and adolescent take the treatment as prescribed and are being observed when they take the medication. The other thing is also that the guardians, they must tell the children about their status early. They counsel support through the community health workers so that they understand that they can still live positively with the condition. Peer support, especially for the adolescents, where they successfully can support others who have not yet achieved viral suppression. So these are among the main drivers when we talk about motivating for, yes.
Okay, great. Thank you, Frederick. So another question, and this one is for Makunda, and people are asking if you could share some details on how viral load results are communicated to your clients. For example, if the viral load has improved since the last measurement, how do you approach that? Do you provide encouragement or take another route? So that was for Makunda.
All right, thank you for the question. How the results are communicated back to the clients. Once the results is returned from the DNA PCR, it goes straight to the facility that has provided the sample. Then from the system, we normally take some printouts of the results. One results remain on the client file, and one copy of the result is provided to the client once the client visits on the next appointment date. But if the result is unsuppressed, then through the information on the file and the system, the care and treatment system, we quickly notify the client to come at the facility to receive the results. And if the client is unsuppressed, additional procedures, the EAC and other mechanisms which need to be provided to the client will be taken thereafter. So to respond to his question, is that for those who are unsuppressed, we quickly notify them and get them at the facility to take the results and additional guidances. For those which is suppressed, they receive their results on the next visits. Thank you.
Yeah, thank you, Mukunda. So a follow-up question for you. Lana says, I noticed your consortium includes local and international partners. Can you describe how the consortia partners collaborated with each other to successfully build the system that you discussed?
Thank you very much. Maybe specifically to this project, this system was built through the funding from CDC through MDH. I myself work for FHI 360, where I lead the mHealth unit. So I provide the leadership, the deployment, the end user training, but the costs and the other resources to make sure the system is fully deployed, including the equipment, payments of those who attend trainings, the internet funding, the money for SMSs that comes from Deloitte. So it's the work that is done by all consortium. Each one takes different processes to make the whole thing work perfectly.
Thank you. So then maybe one more question, and then we'll work with the moderator, and we want to get 3 main takeaways from all the session attendees. But one more question before we get to that, and this one is for Akinwale. Lana says, I was impressed by the level of important details that your mobile platform is able to collect to help identify which children might be at risk for missing appointments or running out of medications. Given the sensitivity of the data with geographic locations and information, can you briefly discuss what steps you had to take to ensure security and confidentiality of the data? And that was for Akinwale.
Okay, thank you very much. I think that was the major concern before we select the platform to use. And like I said, the COBOL Toolbox platform, it's a UN platform majorly made for such humanitarian activities. So it's a secured platform. And because we are using the case worker who are already working with this household, so that way we are not also putting the household in any line of harm. So the caseworker, having been the one providing the service to them, we're still able to go and collect this. And again, sharing this information, like I said, is just for our own work. The only thing that we intend to share out of it with the treatment partner is the coordinate, because we are working by them in the first place. Most of these children we are gotten from the treatment partner line listen. So just on the co-creation platform, that's only at time we share it with them, so that should in case their own caseworker need to go to this household, it makes it very easy for them to go straight to this household. So apart from our project and the treatment partner project, we don't do any data sharing of this kind. Again, for the treatment partner, we have an MOU already in place, so we both understand this level of sharing. So far so well. The security information are intact for these children. Thank you.
Thanks, Akiwana. That's great. And just thank you so much for all of our presenters. I know we got 4 minutes left. So the last thing I wanted to ask was if each of our 3 presenters could maybe express one takeaway point from today's session, that would be great. And so I'll give each of you a chance to maybe have like 1 minute to talk about one takeaway point from your point of view. And then if I could ask the attendees to also write into the chat box, 1 to 3 takeaway points that you would like, that you have had. We'll take that information and try to consolidate it so that we can get as much information and feedback from you, but also to ensure that the learning of this really met its objectives. So let's start with Zambia, with Mr. Not Mr. Kasonga, sorry, with Mr. Katunga and Mwanza, please. One takeaway point from your point of view.
Thank you very much. My point of takeaway from this is that I have seen there's a lot of knowledge which we have, and sharing through this platform, we can get a lot of ideas from each other that we can use in different programs that we are running. Thank you.
Super. Thank you so much. That's an excellent point, Frederick. So that's very helpful. And Mr. Mukunda Kosongo?
Thank you. So my takeaway message from today's session is that we need to continue using various digital health initiatives so that we could continue computerizing our facilities in our community or services so that we address the issue of virus suppression in our respective countries. Thank you.
Thanks. That's a great point. Okay, and then Mr. Akinwale?
So I'll just add to that to say that using technology can help us to not just only see the figure, but to understand the story behind the figures so that we can best track along the cascade. Thank you.
Great, thank you. Were there any other, again, so if there were any other takeaway points that you would like to include, please feel free to include that in the group chat. We have 2 minutes remaining. And Latham, is there anything else that we need, that we would like to ensure we get done in these 2 minutes?
Just a reminder that we do have our networking hub in the on-air platform. So if you all would like to reach out to your fellow attendees or the panelists, I saw some of the panelists did share their email addresses in the chat. But if you'd like to reach out to other ones, feel free to use the on-air platform, the networking function there, and you can search for panelists and attendees to follow up. Thank you. And there also may be a poll coming up. Keep your eyes out for that. And if you see that, please fill that out. Thank you.
Great, thank you everybody. Just want to give a round of applause for our 3 presenters. Thank you so much for showing us and showcasing some of the innovations that you are implementing in your respective programs, and just the level of integration with existing partners and the networking that you're doing to collaborate and make a successful outcomes in viral load and reaching viral load suppression for the clients that we serve. So FPD, I guess you can start the poll. And I will stop here.